All right, everyone, it's 12 o'clock, right on the hour. So we're going to go ahead and get started. I'd like to again thank everyone for joining us for the Addiction Medicine CME series. And I know I have the information, my wonderful program coordinator sent it to me. The way that we do CME is you text a number to a phone number to get credit. Let me pull it right up. And the CME number is 947287. I'll go ahead and drop that in the chat. It looks like Jamie Manster is helping me out with that as well today. Excellent. Thank you. So again, welcome everyone. I'd like to introduce our speaker today, and that's Dr. Michael Weaver. He's a professor of the Department of Psychiatry and medical director of the Center of Neurobehavioral Research on Addiction, CRNA, at the McGrovin Medical School at the University of Texas Health Center in Houston. He received his medical degree from Northeast Ohio Medical University and completed his residency in internal medicine and a clinical research fellowship in addiction medicine at Virginia Commonwealth University Healthcare System, or VCU. And he's board certified in internal medicine and addiction medicine, and he's currently involved in patient care, medical education, and research. Dr. Weaver sees patients in the Innovations Addiction Treatment Center at Texas Medical Center in Houston, and he has extensive experience teaching about addiction to medical students, residents, and community professionals at all levels. He is involved in multiple research projects and has multiple publications in the field of addiction medicine. Today, he'll be speaking to us about tobacco use disorder. So I will go ahead and turn it on over to Dr. Weaver.
All right, thank you very much for the kind introduction. I'll go ahead and share the slides here. Everyone should be able to see those. All right, so talk about tobacco use disorder. So what I want to try to cover today include the different types of tobacco products. We'll talk about health effects, and then we'll talk about different treatment options, pharmacologic, as well as some behavioral options as well. All right, so we'll start off with smoking tobacco, stuff that people should be pretty familiar with: cigarettes, cigars, pipes. So these are burning tobacco leaves, and so you get to inhale all of the different constituents of those, including tobacco-specific nitrosamines and other known carcinogens, as well as all that particulate matter that leads to a variety of the health complications that we're familiar with. So one of the things that people smoke for is the nicotine, the active ingredient, the addictive component that makes people want to go back and put a stick of burning leaves in their mouth. And it has a double whammy. It stimulates and it relaxes. So it enhances focus and concentration and gives a feeling of energy. At the same time, it causes muscle relaxation and people feel more relaxed. So that double whammy is one of the aspects that makes it hard to stop smoking. And in a little bit, we'll talk more about why it is so difficult for people to stop. One aspect of nicotine that causes some challenges, and again, we'll get more into this when we talk about some of the health issues that it causes, is the fact that as a stimulant, it leads to vasoconstriction. And that's what's responsible for a number of the cardiac effects, hypertension, and other things. It's a very short-acting compound. It doesn't stick around long. So that means that to maintain the desired blood level of nicotine, you have to redose frequently. And this is another aspect of nicotine that can make it very challenging to quit, because this is something that you're doing all throughout your waking hours. When someone is smoking, they are redosing on a regular basis. Just in terms of mathematics, there's about 10 to 12 puffs in any average cigarette, right? Assuming someone doesn't let it burn to ash in the ashtray. So a 1 pack a day smoker is ingesting 200 hits of nicotine. That's an awful lot. That certainly adds up over someone's waking hours and contributes to why it is challenging to quit smoking, because of that level of reinforcement. Now, in addition to the smoking tobacco products that are familiar to all of us, there are also smokeless products. So this includes chewing tobacco, snuff, which is finely ground tobacco leaves, and snus, which you can see from the bottom picture there, already pre-wrapped finely ground tobacco. Now, this isn't as popular as the smoking option. It's only 3 to 4% of the population. But unlike smoking products, which have had a gradual decline over the last several decades, there hasn't been a comparatory decline in use of these smokeless tobacco products. It's maintained very consistently at the same level, people that are using chewing tobacco and snuff and things like that. It's used differently. The nicotine is absorbed across the mucosa of the mouth, and as a result, you get exposure to more nicotine and more direct exposure to the mucous membranes of the carcinogens that are in those tobacco leaves. And that can lead to a lot of health problems as well, especially in the head and neck area. And we have oral nicotine products. These are definitely new. Most of them are sold over the counter, at least for the time being. And so you can see here in the picture, they have little pouches. These are different than snus, or you can have gummies, which are the latest craze. And oftentimes these are erroneously marketed as tobacco-free. Well, obviously, the nicotine has to come from somewhere. So generally that's going to be tobacco plants, but they're trying to make a distinction between smoking and smokeless products that have whole tobacco leaves versus a lot of these may have just the nicotine itself. Most of them are not FDA approved, and in fact, the FDA has rejected proposals from different manufacturers for oral nicotine products to date. And what I think is particularly scary is that this is the most common source after electronic cigarettes for high school students, for adolescents to access nicotine products over the last couple of years. And so this is something we're going to be seeing more of. And then, of course, the 600-pound gorilla, the electronic cigarettes. So these have exploded onto the scene, sometimes literally, and become very, very popular. I want to make sure that you recognize that these aren't intended to help people stop smoking other combustible tobacco cigarettes. They're designed as a substitute. They were initially developed when there were a lot of smoking bans, especially in the United States, preventing smoking in restaurants and bars and public buildings because of the issue related to secondhand smoke. So this electronic cigarette development was really to cut down on secondhand smoke, at least initially, and allow people to get their nicotine fix in places where they could not or chose not to smoke. And you can see some of the advertisements here. This is an actual advertisement for Blue, one of the initial brands of electronic cigarettes. And yes, a lot of those were actually developed and marketed by big tobacco companies. But you can see this lady is flipping off smoking bans because this is a way to get around it. And that was the original purpose of marketing electronic cigarettes. They also wanted to market them to younger people. Initially, there were no restrictions or regulations about these things, and they would have flavorings that would be attractive to younger kids, like birthday cake and bubblegum and things like that, so that they could get more and more people habituated to nicotine that would generally move on to combustible cigarettes. And we definitely see that happening, where young people start with combustible or with electronic cigarettes and then move on to combustible products. They only became regulated in around 2018 when there were restrictions put in place related to age, and then the FDA started taking over regulation, and really there are only a couple of electronic cigarette products that have been formally approved. And even though electronic cigarettes may have some advantages over combustible cigarettes, in that you're not getting all of the different constituents of tobacco smoke, all of the particulate matter and all of those carcinogens, there are still other components that are in the e-liquids that's vaporized. And we'll talk about those in just a little bit. But that too can be potentially dangerous because it's not just pure nicotine that's being inhaled. So these things may be a little bit safer than combustible cigarettes, but they are certainly nowhere near as safe as inhaling just plain old air. There have been a few generations of the electronic cigarettes that have been developed. The first ones we called cigalikes, and they were intentionally designed to look like traditional combustible cigarettes, same sort of size and shape. A lot of them had a LED light on the end that would light up like the burning cigarette. But fairly quickly, they moved into the second generation where you had refillable tanks and more ability to adjust how much nicotine you were getting. The third generation of electronic cigarettes didn't look much like cigarettes at all. They looked more like flashlights or cologne bottles or something like that, depending on the size and shape of the refillable tank. And you had more options to adjust the voltage and things like that to be able to really fine tune or increase nicotine consumption. And so now we're in the fourth generation, and these are the pod mods that have been around for the last few years. Most notably, Juul has promulgated a lot of these, but there are certainly plenty of other manufacturers that have similar sorts of pod mods. And even though it's a small container with liquid nicotine in it, it's concentrated so that one of these pods is equivalent to roughly a whole pack of cigarettes. And the big advantage of these, unlike some of the second and third generation electronic cigarettes, is that these are small, discreet, easily concealable, and they look like a USB drive. In fact, many of them are charged in a USB port. And so it's very popular to use these in places where you might not otherwise be allowed to use cigarettes or electronic cigarettes. So middle school and high school bathrooms are extremely popular locations for these to be used. And adolescents are actually more likely to use this type of pod mod than a lot of adults are. And then we have the e-liquids. This is the stuff that is put into a refillable tank or that comes pre-filled in the disposable electronic cigarettes. And so you can have different concentrations of nicotine so that you can decide how much of a buzz you want. And it can be very high, or people can buy it in a smaller amount and then dilute it out to a level that they want. But if you are mixing different kinds of e-liquids, you need to be very, very careful. Nicotine is easily absorbed through the skin, and high doses of nicotine can be very toxic. In adults, you can have, at minimum, nausea, at worst, seizures and death. And young children have died as a result of high concentrations of nicotine in an overdose situation. The nicotine itself has to be mixed with something to stay in a liquid suspension so that it can be heated and inhaled. And so those vehicles are called humectants. The most common ones are propylene glycol or vegetable glycerin. And again, these aren't things that are necessarily designed for human consumption. So we don't know what the long-term effects are of inhaling this on a multiple times daily basis over years. We clearly know what the effects are for tobacco cigarettes, the traditional combustible ones, where you're inhaling that kind of particulate matter over decades of life. But we still don't have all the data for what's happening with electronic cigarettes over long periods of time. In addition, other chemicals wind up in e-liquids as well, different things that are used for the flavorings or some of the solvents that may have been used to extract the nicotine from the tobacco leaves. Also, you can get other kinds of impurities, heavy metals from the soil where the tobacco may have been grown, pesticides, fungus, different things like that have been found in tested samples of these e-liquids. So it's definitely a buyer beware situation, because you may not always know what it is that you're ingesting. And samples have also shown that they readily and regularly exceed the maximum allowable levels of a variety of known harmful compounds. But that hasn't prevented a lot of young people from experimenting with these kinds of products. So teens are more likely to start with these, especially because a lot of the flavorings are marketed towards teens, and they have this reputation of being cool or different or less dangerous than traditional combustible cigarettes. And so, as you can see, some of the epidemiologic data here, 27.5% of high school students, more than 10% of middle school students. So if you think about it, 1 in 10 middle school students has been using an electronic cigarette at some point. And that is intentional. The kind of e-liquid flavorings are designed to be attractive to younger people and get them engaged in regularly consuming nicotine. Young girls too will use nicotine as a method for weight control, and that may be why girls are attracted to nicotine products, whether it's electronic cigarettes or smoking combustible cigarettes as a form of weight control. I mentioned a number of the health effects previously. Nicotine certainly can accelerate atherosclerosis and elevate blood pressure. You also have the particulate matter that's in burning tobacco, and that will lead to chronic obstructive pulmonary disease over time. Carcinogens lead to lung cancer. If people are using smokeless products or with combustible cigarettes, your upper aerodigestive tract is being exposed to all of these compounds over years of use. So that leads to cancer in a variety of places, not just the lungs, but in the head and neck, and then in the bladder as well, because once the nicotine and other constituents in tobacco smoke are absorbed into the lungs, into the bloodstream, across the blood-brain barrier, but then they're filtered out through the kidneys, as well as sitting in the bladder for a while. So bladder cancer is also something that has a significant prevalence in people who are smoking. In terms of mental health issues, I'm sure you're all well aware that patients with psychiatric disorders definitely have significant problems with smoking and electronic cigarette use. Up to 88% of patients who have major mental illness like schizophrenia will use tobacco products. Around 40% of patients with ADHD will, and over a third of all patients across all psychiatric diagnoses are going to use tobacco products, so which is much higher than the general population, which nowadays is well below 20%, on the order of 13%. Among US adults, as it's been dropping over time. And anyone who does have mental health issues often finds it much more challenging to stop smoking. The relationship works the other way too. Folks who smoke will have higher levels of depression and anxiety, and around 60% of smokers have a lifetime history. So again, much higher than we see in the general population. And the suicide risk is higher as well. It's twice that in people who use tobacco products compared to non-smokers or those who haven't used any tobacco products. There are also effects on unborn, so on the fetus. This is the most common fetal exposure. And women who are pregnant may be able to give up heroin, cocaine, alcohol, things like that, but it may be more challenging for them to give up their cigarettes or their vape pen, even when they know they're pregnant. The most common effect we see from exposure to nicotine and to smoke is intrauterine growth retardation. So the fetus is small for gestational age and will have low birth weight at the time of delivery. We also see more obstetric complications in women who smoke during pregnancy, spontaneous abortions, placenta previa, and other issues related to potential for harm at before and during delivery. Even after delivery, you have ongoing risks. So the risk for sudden infant death syndrome or crib death is much higher in a smoking household, 4 times higher than in a non-smoking household. For pregnant women, the American College of Obstetrics and Gynecology first recommends trying to use behavioral methods for smoking cessation, but because women are already exposing themselves to nicotine, nicotine patches are certainly reasonable and a much safer alternative to cigarettes or electronic cigarettes during pregnancy, because it's exposure to just the nicotine as opposed to all those other constituents that I've talked about previously. We don't have a lot of data on some of the other pharmacologic options that I'll talk about, but any of these options would be a benefit in pregnancy compared to continuing smoking, and none of them are known to be teratogenic or have higher incidences of obstetric complications compared to smoking itself. So with all of these harms, mental health, physical health, and all of that, why is it so hard for people to stop smoking? Well, nicotine itself can be just as addicting as heroin, cocaine, alcohol, and these other drugs that we tend to think of. However, it's less intoxicating. And so someone who's smoking isn't as impaired as someone who is drinking a few beers or snorting cocaine, injecting heroin. The impairment is not as intense and not as obvious. So we don't think of it as being problematic in the same way. But nicotine receptors in the brain are stimulated, and the dopamine reward system is activated. And so, as I mentioned, you have these pleasurable effects caused by ingesting nicotine. And that lights up our brains in ways that people enjoy significantly, both stimulation and relaxation. And this frequent use leads to association with whatever it is we're doing at the time we're smoking. Driving in the car, talking on the phone, after a good meal, all of those sorts of things become associated with the presence of nicotine. And so the habitual behaviors of seeking, lighting up or getting out the vape pen, self-administering cigarettes, electronic cigarettes, getting out a wad of tobacco from the pouch, all those become part of the routine, and they become associated with whatever it is people are doing throughout the day. And so nicotine becomes important in how people regulate their mood. They may suppress their appetite, increase their energy level, and do it as a way to deal with boredom, depression, anxiety, other forms of stress. So that can make it very, very challenging for people to stop smoking, because it's just associated with so many things, or used as a subtle and reliable mechanism for dealing with these kinds of situations to modulate people's mood on an ongoing basis. And then, of course, there's nicotine withdrawal, the physical sensations that are associated with cessation of nicotine products. So people want to re-experience that relaxation and stimulation. And so there are going to be cravings when it goes away. And withdrawal is basically the opposite of the kind of effects that people are getting during active use. So instead of being able to concentrate and feeling relaxed at the same time, people get irritable, angry, easily frustrated, They're anxious in general, including about what are they going to do if they keep feeling this way. There's difficulty concentrating instead of having higher focus, and people are kind of restless and don't know what to do with their hands if they don't have that cigarette or that vape pen. Because nicotine is a stimulant and elevates your heart rate, people will have a decreased heart rate when they're trying to go without, and that may make them feel sluggish. They don't like that feeling of less energy. With increased appetite, you get weight gain, and talk more about that in a minute. And then instead of feeling more euphoric, more relaxed and stimulated, there's depression, difficulty sleeping, even some sedation. So these are unpleasant. They're not as awful in the physical sense as withdrawal from alcohol or opioids, but they start quickly, last a while, and are very, very annoying, and are one of the main reasons why people will return to cigarette use. Or if you have a household member that's trying to stop smoking or quit using an electronic cigarette, the spouse or roommates or other family members will basically say, oh, just go ahead and smoke. You're really, really annoying us with how grouchy you are. And again, the reason why people may go back to utilizing nicotine. It usually begins about 24 hours or less after the last cigarette, depending on what blood level people are able to tolerate, and it lasts for several weeks, often out to a month. The good news, though, is that after that first 7 to 10 days, the worst of the cravings and withdrawal symptoms tend to drop off. So if you can make it through that first week or so, after that, it does get easier. The problem is most people will resume using nicotine within the first 3 or 4 days, just because they don't like the way they feel, and they can very easily and reliably make themselves feel the way they want to just by going back to using their nicotine product of choice. Now, some of the lingering effects, the kind of random occasional cravings for nicotine and appetite alterations can last for several months. But again, the worst of it tends to be over in the first 7 to 10 days, and it gets progressively better after that. I try to do a lot of anticipatory guidance with my patients around cessation of nicotine products and let them know what to expect. For smokers, there's going to be a temporary increase in cough, and that's not because as soon as they decide to quit, they've now developed lung cancer or something like that, which a lot of people do worry about. It's because the aerodigestive tract is waking up, and so all their cilia are starting to work again, and they're starting to work on getting rid of that backload of crud that people have been inhaling for years and years while they've been smoking. So when you stop smoking, it's actually a good thing that you're trying to cough out all of the stuff that you've been putting into your lungs for a while. I mentioned weight gain, and it's not just because nicotine's an appetite suppressant and people's appetite comes back after they stop. It's also that all of that hot smoke or the liquid that people are vaping all through their upper respiratory system, that can really deaden your taste buds. So when people stop, their taste buds start to wake up, and guess what? Food tastes really good again. And so they want to enjoy it. They forgot how good a meal can be. And so they tend to want to enjoy the experience and eat more, and that leads to weight gain. I mentioned nicotine withdrawal symptoms. And then, of course, if someone is in a household with others who are smoking or using electronic cigarettes, that can make it very, very challenging to quit. If you have more than one person that is trying to quit altogether, their chances of success are much greater. If you only have one person trying to quit and the others are not, then misery loves company. So those who are still smoking or using the electronic cigarettes are often going to try to get the person who's quitting to go back to smoking through peer pressure or there will be so many cues and triggers that it becomes much more challenging for that person to remain abstinent. There are some environmental prevention mechanisms. I mentioned some of these already. Some restrictions now that tobacco products have moved under the FDA. There have been age limits for a very long time for tobacco products, and more recently on things like electronic cigarettes. There are more recent restrictions on flavorings. Some of the more popular flavorings you are unable to get at brick and mortar stores if that's where you're buying your electronic cigarettes, but that doesn't extend to buying over the internet. So you can get your e-liquids, you can order them from other states and other countries, and whatever flavoring you like, including your birthday cake and unicorn rainbow flavor, whatever it is that's attractive to younger people. Unfortunately, smoking bans have included combustible cigarettes for a long time, and very quickly expanded to electronic cigarettes in public buildings, hospitals, airplanes, and the like. All right, let's spend some time talking about how we can help patients to quit smoking with various forms of pharmacotherapy. So we'll go over in detail the different forms of nicotine replacement and what we can tell our patients about what they can expect from using these, as well as the prescribed medications that are FDA approved to help people stop smoking. And these can be also applied to other nicotine products as well. So nicotine replacement has been around for a while. It went from prescription to over-the-counter a number of years ago. So it is widely and easily available. And there are a number of well-known brand names, some of which are still advertised on TV. But most of the pharmacy chains are going to have their own house brands. So there are generic equivalents out there that's brought prices down in general, which is a good thing. So it is pharmacotherapy, it's replacement therapy. You are giving them back the nicotine that they had been ingesting through combustible cigarettes and electronic cigarettes, but this is in a more controlled setting and without the other harmful constituents that are in tobacco leaves or e-liquids. And have on the slide here that patients shouldn't smoke while using, but plenty of patients will certainly try it. One of the first indicators of nicotine toxicity, so being exposed to more nicotine than you have tolerance to, is nausea. So that may help it to be somewhat self-limited, although there are patients who will just take off the patch or spit out the gum when they want to smoke or get more of a hit from an electronic cigarette. So the patch has been around the longest and has the highest success rate of the different forms of nicotine replacement. Again, a number of popular brand names like Nicoderm, Nicotrol, Havitrol, Prostep, but nearly all of them are very similar in terms of having three specific strengths of nicotine release over time. So with the patches, you've got 21 milligrams, 14 milligrams, and 7 milligrams. The reason you start with 21 milligrams is that most cigarettes contain around a milligram of nicotine that is ingested. So a 1 pack a day smoker is ingesting 20 milligrams of nicotine. So the patch is aimed at about that, maybe just a little bit more to make sure that you overcome that nicotine tolerance in order to thoroughly prevent withdrawal symptoms. Now, if someone is smoking more than a pack a day, you can have them put on more patches or mix and match the different strengths to get it to be as close as possible to how much they're smoking. However, someone who's only smoking half a pack, it's okay, it's safe. You can still start with the 21 milligram patch, even though that's maybe more nicotine than what they were used to initially with how much they were smoking. So they all work similarly. You start with the highest strength patch and put one on every day for 6 weeks. Then you drop to the next lower strength, do that for around a month. Step down to the third strength, the lowest strength, and do that for another month or so. But of course, you can extend the time if necessary. If people are having difficulty, you can extend the time at any of these levels to make sure that people are more likely to be successful. Now, there are some reactions to the patch. Not to the nicotine itself, but to the adhesive that holds it on. Some folks can get a rash from irritation. So what I'll do is tell them to put it in a different spot each day. But you can't put it anywhere on your body. You get the most consistent absorption above the nipple line, so the upper chest. Typically, I'll tell my patients to start over their heart and put it on the upper chest above their heart on the left side. Then the next day they move it to their left upper arm. They can put it above their shoulder blade, on their back, and just keep moving on around so that by the time you get back to the original spot, it's been almost a week. So any rash, irritation, anything like that is from the adhesive has cleared up completely. Or you can use a little hydrocortisone cream over the counter to clear it up as well. And so the patch has been very successful and very easy to use. One other thing that I'll hear patients say about the patch is that they'll have very vivid dreams, not necessarily nightmares, but they remember dreaming a lot. They have very active dreams. That's because people tend not to smoke while they're asleep. So your body's not used to having nicotine in the bloodstream throughout the night. And so that stimulation may cause a lot of these vivid dreams that people experience, but it's very straightforward. I just have my patients take the nicotine patch off when they go to bed, and that way, you're not having the vivid dreams if it's problematic for some people. Now, for very heavy smokers, that may mean that their nicotine blood level will drop unacceptably low in the morning, and so they'll have more cravings. So those may be folks that you might want to encourage to try to keep on overnight so that they at least have some nicotine in their bloodstream for the next morning when they switch to a new patch, so that they're less likely to have cravings at that vulnerable time. Then there's nicotine gum. This is also popular. A number of brand names of this, but again, all of it's pretty similar in terms of the dosage and the way it's used. You have 2 milligram or 4 milligram pieces. A lot of them come in boxes or packages of 10, and ideally, you don't necessarily want to do that, use a whole package in the course of a day. Had a patient that said, oh, yeah, I started using the nicotine gum the other day, and I'm doing a pack of 10 of them during the day, and they're the 4 milligram pieces. So I had to point out to him that that's equivalent to smoking 2 packs a day, whereas before he was smoking less than a pack a day. So he realized he needed to ratchet down pretty quickly, and plans to do so. Now, with nicotine gum, you don't chew it like juicy fruit or Hubba Bubba. It's a different way of getting the nicotine out of it. It's not really gum. It's as you can see on the package, a Palacrolax. And so, picture says lozenge. Anyway, but the gum itself, you will put it in your mouth, chew it a few times, and then you park it between your cheek and gum and let the nicotine be absorbed across the mucous membranes that way. And the nicotine's being released because it starts tasting kind of bitter and peppery. And then as the nicotine's absorbed, you can take your tongue and flick it out, chomp it a few more times, park it on the other side. Basically, just do this until the nicotine is extracted from the piece of gum, which takes about half an hour. So use one or several pieces every hour or two throughout the day, just kind of as needed for nicotine cravings or to prevent nicotine withdrawal symptoms. And you try to be consistent with the same number of pieces over the course of a day over about the first month. And then I'll have patients just reduce by a piece every week or couple of weeks, something like that, depending on what number they started with, and then drop down over several months. And that tends to work well for most people. Nicotine lozenges are an alternative to the gum, and similar doses, similar way of using it, although instead of chewing a piece of gum, you're just sucking on the lozenge basically over time, and reduce the amount over several months. These all the gum and the lozenges come in different flavors. Some people may prefer different flavors, although I've certainly heard from other people that it's a little bit like trying to flavor diesel oil. There's just not much you can do about it with that kind of peppery taste of the nicotine that you're extracting in your mouth. All right, let's talk a little bit about prescription options. Okay, so there is bupropion, sold under the brand name Zyban for smoking cessation. But this is the same thing as the bupropion in the brand name Wellbutrin antidepressant. Dosing is also fairly similar as well, 150 milligrams, and you actually ramp up the dose over the first few days. This is a bit more of a stimulating antidepressant. It works on dopamine and norepinephrine receptors. This helps with withdrawal symptoms and cravings, and some of the feelings that nicotine will give people when they take the bupropion. It helps them to feel more satisfied without having all of that nicotine. But because it is a bit more stimulating, you get some side effects. It can cause some difficulty sleeping, especially if they're taking it later in the day. People may feel a little bit antsy or jittery. Potentially, it can lower the seizure threshold. So people who have epilepsy should not take bupropion. Although I found it to be very well tolerated for most people, all things considered. In terms of dosing, you actually start it before you quit smoking or using the electronic cigarette, anywhere from a week to two before that quit date, or before you're supposed to give it up. And the dose increases over the first few days from once a day to twice a day. They come in the little blister packs that make that easy to know, which pill to take and what dose. And you take it for around 3 months. There's an option to extend that another 3 months for a total of 6 months. And since then, over the years, we've found that people can take it longer than that if necessary. If they are still having cravings, or still having the occasional nicotine product, or just feel like they want that additional peace of mind that they're not going to go back to using nicotine products. And because it's an antidepressant, it has certainly been used long term, and we've got plenty of safety data for that. In addition, whether you get it by prescription or generic, it does come with its own behavioral program. And I thought it was very interesting that when GlaxoWellcome, the manufacturer of Wellbutrin, went to the FDA, they wanted to market Wellbutrin for smoking cessation. And the FDA said to them, no, we want you to market it under a different brand name, and we want you to include a behavioral program with it. So the behavioral program that they came up with is 1-800-YOU-CAN-QUIT. So you dial the toll-free number, and you're able to talk to someone who's basically a smoking cessation counselor. They'll get information from the individual, and they will mail you or tell you what website to go to for additional information with tips and tricks and hacks on how to quit. You can get text messages or emails with information and encouraging messages. They'll call back on your quit date and shortly after, and see how things are going and offer more encouragement. So fairly minimalist, but not badly done, because they certainly have a vested interest in people being successful. So that's bupropion. And then we have varenicline, brand name Chantix, although it too is generic. And it's a nicotine partial agonist. So somewhat the same way buprenorphine is an opioid partial agonist, varenicline is a nicotine partial agonist. And it is administered exactly the same as bupropion. You start a week or two before you quit smoking. You ramp up the dose over the first few days. Take it for 3 months, can extend that out as long as necessary. It too includes a behavioral program, but because it was FDA approved a number of years later than bupropion was, instead of 1-800-YOU-CAN-QUIT, their behavioral program is getquit.com, with this kind of multimedia website or app with many of the same features that I already mentioned about getting helpful text messages or calls, tips and tricks. And with the app, you can kind of keep track of when you quit and all of that. So certainly can be helpful for folks that are already motivated enough to get a prescription to help them stop. So how do these stack up to one another, and how helpful are they? Well, there certainly have been a lot of studies with nicotine replacement, which is over the counter, widely available, that will at least double your chances of successfully quitting smoking. Then bupropion is comparable to using nicotine replacement. And then the one that's been most successful is the varenicline, with the highest rates of continuous abstinence from tobacco products compared to the others. Another thing that we've found over the years is that it's actually preferable to combine these different options. So you don't have to go with just one. In fact, any combination is more effective than any single product alone. A simple way to do this is use the nicotine patch for continuous nicotine, and then use gum or lozenge when people have cravings, such as at times when they would typically smoke while driving their car after they get home from work, or with a cup of coffee or that sort of thing. So you can combine those forms of nicotine replacement. You can combine both forms of nicotine replacement with bupropion or with varenicline. And then you can even combine varenicline and bupropion together. They don't interact, and they may be particularly good for very heavy smokers. So basically mixing and matching these is the way to go, and can improve people's chances of success at successfully stopping use of all nicotine products. Of course, behavioral treatment is important as well. I mentioned I do a lot of anticipatory guidance, and I also try to offer some suggestions for my patients to help them to be successful in terms of environmental control. I tell them, smoke up your last carton, get rid of all the cigarettes, or throw out the vape pen and all of that. Get that stuff out of the house so that you're not tempted. Throw out or give away the vials of e-liquids. Get the ashtrays out of the house so you don't see those and have cravings. Try to make the environment as conducive to not smoking or not using an electronic cigarette as possible. If someone does have a craving, there are certainly ways to deal with it. Nicotine cravings last maybe around 20 minutes at the most. So if you can distract yourself that long, then the craving will subside and you don't have to go and puff on a cigarette or reach for the electronic cigarette. And basically it's as simple as doing anything that you enjoy. So playing a game on your phone, or going for a walk, or calling a friend. One thing I found, if there's nothing else that they can think of, drink a glass of water. So that a cold glass of water, especially. So if they have to stop, go to the kitchen, get out a glass, turn on the tap, put in the water, get ice, and then drink it all down, and that helps with that oral fixation, then by the time they've done all that, the craving has generally subsided, and you don't get any calories from water, so it's not a bad activity. And for the oral fixation, people can also use, sugar-free hard candy or lollipops, gum, those sorts of things. And you can see some other suggestions here, exercising, listening to music and whatnot. So giving these kinds of suggestions to patients can help to prepare them, not only the environment, but having a plan for if they do feel a desire to go back to using a nicotine product. A great website that's a wonderful resource that has pretty much everything I've talked about is this one, smokefree.gov. So this is our tax dollars at work, sponsored by the U.S. Department of Health and Human Services, as well as the National Institutes of Health and the CDC. It's free for people to go on and get information. This is from the government, so it's unbiased. They're not trying to sell you anything, not sponsored by any of the particular products or anything like that. And people can sign up for text messages or emails and things like that right on the website. Now, if you have a plan that charges by the text message or whatever for your phone, okay, there may be a cost involved with that. But other than that, the signing up for it and getting them sent out, no cost to that. There's a smartphone app as well as a website and lots of information about tips and tricks, most of which I've already mentioned, as well as lots of information about pharmacotherapy. And for folks that are on Medicaid, you can actually sign up to get free nicotine patches as a covered benefit for Medicaid. So I recommend this to all my patients to find out information and get additional support. So we do want to leave some time for questions. It's a lot of information in less than an hour. So here are just a few take-home points, lots of different nicotine products, but all of them are dangerous in terms of health problems. But the good news is we have lots of ways people can be successful at quitting with nicotine replacement or prescription medications. And remember what I said about combining them to improve the chances for success, as well as various behavioral methods that we can talk to our patients about to help them to be successful. For those who want some more information, there are a number of good articles here. Great review in JAMA, Journal of the American Medical Association, from last year, as well as a publication here from the American Society of Addiction Medicine, and some other articles and books. So we do have a few minutes for questions. So I'll turn it over to Dr. Gum if you want to moderate if anyone has typed anything into the
we've
chat,
got a
or
couple
feel
questions
free
here.
to unmute themselves.
So it looks like our first question in is from Dr. Bovee. She is wondering your thoughts on the nasal spray and how do you, if you agree with the nasal spray, how do you write the script and dosing instructions?
Okay. So I didn't really mention the nasal spray because it's not used as much nowadays. But yes, it is out there. It is by prescription. So it's a form of nicotine replacement. It's a little more like the gum or the lozenge in the way that it's designed. You use a squirt in one or both nostrils. You can do that about every hour or so during waking hours. But you are getting a dose of nicotine that's more quickly absorbed from the nasal mucosa. It's a bit closer to the rapid absorption of nicotine across the membranes of the lung, as opposed to something like the nicotine patch, which is through the skin. And so it's kind of in between smoking or using an electronic cigarette and using something like a nicotine patch, but it can be a little bit more challenging for people to quit the nasal spray, which is why it's by prescription and really shouldn't be continued for longer than a total period of 3 months. If people haven't quit by then, you really should be exploring alternative strategies so that they don't just end up using the nasal spray in lieu of other nicotine products. You might think of it as a form of harm reduction, but there are some side effects to it. It can irritate the nasal mucosa, so people can have sneezing, burning sensation in the nose, nosebleeds. Especially with the advent of more of the nicotine gum and lozenges and even electronic cigarettes, that hasn't been used quite as often, especially because it's by prescription versus having other forms of nicotine replacement readily available over the counter. So hopefully that answers the question. It is available. There are some restrictions on it, and there are reasons why. But yeah, for folks that may have had challenges with other forms of nicotine replacement, that certainly may be an option worth exploring.
All right. And another question, I have a question. Is there a compliance difference by the type of replacement therapy modality? And goes on to list a couple of examples where one might prefer one modality over the other. But the basic question is there a better modality in certain patient populations?
Well, again, this is, what you would determine on a case-by-case basis from discussing with your particular patient that is sitting across from you. So, it depends on, when is it that they typically smoke, or when do they get the most cravings, or, how do they do it, or what have they tried before that has been more or less successful. And as I mentioned, combinations are great to use, so you can try to mix and match to put together a plan that's going to help your particular patient be most successful. So I've had patients that may have smoked the most when they got home from work. So if you have a nicotine patch for round the clock use, then combining that with gum or lozenge when they get home from work for those cravings that they know are more likely to occur at that time of day. Or if someone wants to start with varenicline and it takes a few days to ramp up for full protection, so to speak, you can start with a nicotine patch or any of the other nicotine replacement options while that varenicline is kicking in. So really, it's just a matter of talking to the patients about what might be most helpful in order to put together a plan that's going to work for them, and a multi-pronged attack is more likely to be successful.
Awesome.
I hope that gets at what was being asked.
I think you did a great job. And I have a personal question. We got like 2 minutes left. What have you been doing, or how have you been pivoting with the cessation of manufacturing of varenicline or the back orders?
Right. So the manufacturer of brand name Chantix had some quality control issues. So there were some bad batches right before it was set to go generic. So the FDA actually allowed people to import from Canada, or there's another generic version, varenicline, that they allowed to be used as a substitute. So that was over a year ago. A lot of those supply issues have been largely resolved. And again, much of it was related to bad batches at the time that were recalled. But also now that it's gone generic, there are more generic manufacturers that have ramped up. So I haven't had as much difficulty. In fact, haven't really had any significant difficulty in recent months with patients obtaining varenicline.
Awesome.
Other questions or comments?
Nothing in the chat. Getting tons of comments on how fabulous and wonderful your presentation is. I do appreciate it. I think that other substances kind of get the limelight quite a bit with all the education out there on them. And we have a tendency to forget that like tobacco is probably our #1 most used substance out there. after caffeine, actually. So I greatly appreciate your time and presenting to our community.
It's my pleasure. I appreciate the opportunity.
All right. Well, we'll welcome everybody back the next first Thursday of the month, and it will be a